you'll see that we've got a statewide network of hospital-affiliated support groups, libraries of literature, a helpline, advocacy for people with Tourette, newsletter, very, very helpful website. Our latest offering, which is the Wednesday webinar series, the annual Children's Scholarship Award, the Educator of the Year Award, Healthcare Provider of the Year Award, which goes to a New Jersey professional who's made a difference in the life of a child with Tourette. We provide statewide in-service training and college workshops for educators, in-services and grand rounds for clinical and medical professionals. Many of you are aware of and participate in our partnership program with Rutgers University. It's a practicum for doctoral students to study Tourette and work with Tourette syndrome families. New Jersey Center for Tourette Syndrome is actually a collaborative effort among Rutgers University, TSANJ, and community agencies and practitioners across the state. Very last thing on that list is the New Jersey Center for Tourette Syndrome Cell and DNA Sharing Repository. As many of you know, in June of last year, we established the world's first sharing repository of human cells and DNA for Tourette syndrome research, through which we will make samples available to qualified researchers all over the world to study the genetics and find a cure for Tourette syndrome. I cannot urge you enough to participate in the study. It's the very first research study that has been undertaken for Tourette syndrome in the state of New Jersey, but more importantly, it's the world's first sharing repository through which we will encourage research and hopefully a cure for Tourette syndrome. For more information on the research program, please visit our website at njcts.org or call the Tourette Syndrome office at 908-575-7350. I would like now to introduce our presenter for the evening. With more than 20 years' experience in nursing, Susan Wightman-Hentz began her work with the Division of Neurology at Children's Hospital of Philadelphia in 1998. Over the years, she has worked closely with neurologist Dr. Larry Brown and psychiatrist Dr. Tony Rothstein, both of whom are nationally recognized experts in treating Tourette syndrome and its associated disorders. As a pediatric nurse practitioner, Susan provides coordinated care for children with neuropsychiatric disorders, including ADHD, Tourette syndrome, obsessive-compulsive disorder, oppositional defiant disorder, Asperger's disorder, as well as other general neurological disorders. It is with great pleasure that I turn our presentation over to Susan Wightman-Hentz. Susan, welcome.
Thank you, Faith, very much. That was a glowing introduction. I hope I can live up to the laudits there. Anyway, I'm an ex-teacher from many, many years ago, and I wanted to just do a couple of things here. This is my own housekeeping part of it. Question and answers, as Faith and Kelly both said, will be taken at the end of the presentation, but please feel free to type in questions as they come to you, and we have an organizer, Kelly, who will be essentially giving them to me towards the end so that I can hopefully answer many of your questions at that point. Then later, if I can't get to them all by the end of this presentation, they will be posted on the chat board at the New Jersey Center for Tourette Syndrome website, and over the next 7 days, I'll try to answer questions as completely as I can. Please realize, however, that I cannot answer specific questions about your child or your child's disabilities because in essence, I cannot treat your child over the phone or over the web. Questions will be fielded with regards to general concerns about Tourette and related problems, as well as general questions about treatment options. So, having been a teacher, I always was taught that you start with objectives. So at this point, we'll just kind of quickly run through what we hope to accomplish. By the end of this, we hope that you will all be able to identify the signs and symptoms of Tourette syndrome. Of course, I'm probably speaking to the choir, so many of you already know this. Please also, you'll recognize that obsessive-compulsive disorder, or OCD, ADHD, also known as attention deficit hyperactivity disorder, depression, and many other mental health issues may be likely co-occurring conditions with Tourette. We'll also identify the need for collaborative treatment using a number of services, including psychiatry, neurology, psychology, and social services in the care of children, adolescents, and adults with Tourette. We're going to discuss various treatment approaches, including behavioral approaches, medication approaches. Actually, that combines the objective number 4 and 5, looking at medications for all of the different, not all of the different associated mental health issues, but some of them, the most common ones. Okay, Tourette syndrome. As an introduction, and I think this is probably very appropriate since this is our first Wednesday webinar, Mr. Tourette, actually I think he was a doctor, pretty much said everything about the condition really is quite extraordinary, and you can read the slide as well as I can. But it's interesting because the children, adolescents, and adults who have the tics associated with Tourette often have these mannerisms that sometimes appear to be intentional behaviors, and others think it may be malingering. They may think that the child or the adolescent has control over their mannerisms, and in fact they discipline them for it. And in the past, people used to think that the children had symptoms from some kind of supernatural origin. Historically, it was first described really in the 19th century, and they did some studies of hysteria and chorea, and that's kind of interesting because there is a disorder called Sydenham's chorea, which is caused from the antibodies to strep, and thereby I was not involved in it, but some devised this theory that Tourette disorder is caused by Streptococcus bacteria. That's actually not the case at all, but in fact there may be some correlation with a few children who have similar kinds of disabilities, but we're not actually going to get into that tonight. Then, bless Dr. Freud, he talked about psychoanalytic explanations for Tourette, many of them blaming on parents for, chaotic households or overly disciplining children or whatever, none of which have really held out in practice. Then in the 1960s, they've discovered the efficacy of haloperidol, also known as Haldol, and people began to think, gee, maybe there's, really adequate treatment for this. The 1980s began looking at the genetic studies, and the 1990s looking at neuroimaging, such as MRIs. So definitions: a tic, sudden, repetitive movement or gesture, sometimes mimics some fragment of normal behavior. Often the child kind of masks the tic by making it seem as if it's an intentional thing. Premonitory sensory urge is that sense that a tic is going to occur or a tic needs to occur to relieve this sensory urge. And think of it as you itch, therefore you scratch. So children often will have some sensation that needs to be resolved, and so they have the tic to resolve it. Motor symptoms, meaning movement symptoms, are divided into two different kinds. Simple motor tics are very fast, meaningless movements like eye blinking, grimacing, snapping, head turning, that sort of thing. Complex motor tics are more obviously complex, involving several muscle groups, and seem to be more purposeful and can be as odd as kissing or hopping. I've even seen children almost genuflect as they're walking and have an odd tic like that people look at them and wonder, goodness, what is this? Phonic symptoms or vocal tics are also divided into simple or complex. Simple ones often sniffing, coughing, throat clearing, animal noises, squeaking, and any number of different things. The complex ones are more words, phrases, repetitions, and coprolalia. Coprolalia is the one that everybody is afraid their child is going to have, and this in a phrase means a child saying bad words. So the clinical syndromes, transient tic disorder is any tic disorder of any kind, any combination, or any severity lasting less than a year. And obviously, when one is diagnosed with a transient tic disorder, it is a waiting game to see how long it's going to last. Chronic motor tic disorder is movements only for over a year. Chronic vocal tic disorder, which is actually quite rare, is any vocalizations over a year, but in the absence of motor tics. Tourette disorder, or Tourette syndrome, is a combination of both motor and vocal tics lasting over a year. And that truly is all it means. Many people say that Tourette syndrome means it's very severe, or parents will say, oh my God, my child has Tourette syndrome, what a horrible diagnosis. When in fact, I have a number of children who meet criteria for Tourette disorder, but never have required medications and never will require medications for their tics because they simply aren't that intrusive. Tic disorder organic, I put that in there mainly because I use this for billing purposes because all of the others are considered mental health diagnoses, and insurance companies tend to they don't reimburse well for mental health diagnoses. And I think that's very unfortunate. And don't get me started because I'll get on my bandwagon about the whole mental health insurance industry. But in truth, all tic disorders are organic. So I am very justified in diagnosing them organic and telling the parent they meet criteria for Tourette. So the DSM-4 criteria for Tourette syndrome is as follows. Both motor and phonic tics or vocal tics that have been present at some point, I hate the word or the phrase during the illness because I don't think of it as an illness, although they don't necessarily have the motor and phonic tics at the same time. Tics can occur many times a day, and often they have tic-free periods, but the tic-free periods are not more than 3 consecutive months. Onset is before the age of 18, although it's rare that it happens in the teens. It's rare that the first occurrence happens in the teens. It's usually at an earlier age. And the other is the caveat that the disturbance is not from the direct effects of substances or another medical condition. So the frequently associated behavioral symptoms, ADHD, or any of those core symptoms of ADHD, attentional issues, hyperactivity, impulsivity, obsessions and compulsions are often associated, anxieties, ritual, and panic, emotional ups and downs. Often the angry outbursts are a hallmark of behavioral issues with children with Tourette. Mirror phenomenon or echo phenomenon, echolalia, where children will repeat a word. Palilalia, they'll repeat their own word. Echopraxia is echoing a movement. Oppositionality and defiance. I say the phrase oppositional defiant disorder, and honest to God, I have some people who say, and what is that? And I'll say exactly what it sounds like. You have an oppositional defiant little kid. Very difficult. It makes life very difficult for parents and for the child. And it creates a treatment difficulty as well. Social skills deficits. A lot of people don't see that this is a problem with kids with Tourette, but it is. And in fact, they just don't understand the nuances of the nonverbal communication that most of us get. So in a phrase, they just don't get it. To quote a colleague, when the day comes that they find the genes for Tourette, ADHD, OCD, anxiety, depression, oppositional defiant disorder, and bipolar disorder, they're going to find that they're all clustered together. So hopefully with the help of the New Jersey Center for Tourette Syndrome and Rutgers University, they'll be able to find some of these genes sometime in the next several years. So in actuality, it's quite unusual for a child to manifest only as Tourette without the other behavioral issues. And when I evaluate children with Tourette syndrome, and all they have is motor and phonic tics with no behavioral issues, no attentional issues, no school issues, I always say in my final summing up paragraph, this is a child who meets criteria with Tourette, who is blessedly free of all of the other behavioral issues. Because I always consider that that is a blessing. And tics, in and of themselves, are rather, if they're not terribly intrusive, they don't need to be treated. And if they are intrusive but without the behavioral issues, they're not that difficult to treat, usually. Interestingly, sometimes the tics are so visible or so intrusive that they're the presenting complaint and you don't see the other behavioral issues. Sometimes the other behavioral issues are so problematic that nobody notices the tics until you treat the behavioral issues. So what's the prevalence of tics and Tourette? Well, it varies based on your study. Transient tics, it's in my slide here it says 14%. That's based on, I think, a rather prominent study that was done in the 80s or early 90s. And in fact, a more recent study looked at children in special education classrooms and non-special education classrooms and found that tics were evident in probably more like 25% of the children overall, not just special ed, higher in the special ed classes, but around 25% overall. They seem to be more evident in boys than girls. Chronic motor tics are quite evident. Again, these are the kids who've gone beyond the year of transient tics. And Tourette syndrome can be anywhere in 1 to 2,000 or 1 in 200, depending on which study you're looking at. So comorbidity, obsessive-compulsive behaviors, that's not the disorder, but the behaviors, are so common in children with Tourette syndrome that somewhere between 30 and 60% of kids with Tourette have obsessive-compulsive behaviors. And again, depending on your study, anywhere between 7 and 42% have the disorder. ADHD, clearly, half of kids with Tourette have ADHD and about 25% have learning disability. Thus, the study looking at special education, which is obviously kids with learning disabilities or learning issues, many of them have Tourette syndrome. Okay, so I was very happy to make this little slide because I'm finally getting to learn how to make fun slides like this. So often, actually I'm going to back up here, ADHD is the first disorder to be identified in a young child. Often this happens around the age of 4 to 5 to 6 years of age. And then a little later, they begin to have some tics, which then turn into chronic tics because they've been over a year. And then often they realize, whoops, they're not only motor tics, but they're phonic tics as well. And then as the kid gets a little bit older, they have some obsessive-compulsive mannerisms or behaviors. So the typical history is 4 to 6 is the onset of ADHD symptoms, and then a little later, simple motor tics, and a little later, some obsessions and compulsions. The tics then become more complex as the child gets older, and over the age of 12, they often have the complex phonic tics, although I have seen them in the younger child very frequently. And, you know, people say, well, how can a 6-year-old have coprolalia, which is the bad words? Well, coprolalia in a 6-year-old is potty talk. So a little 6-year-old who says poopy, 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 you know, this is his idea of coprolalia. And we as parents will go, stop saying that, that's not appropriate, when in fact it is a compulsive tic, as Larry Brown used to say, where they feel compelled to say something that is inappropriate. So here's the sad part. From the time of the first symptoms of tics to the time of diagnosis may very well be 7 years and sometimes far longer than that. Sometimes this is not an issue. I actually met a 15-year-old who came to me for treatment, and his parents knew that he had tics for years, but they never caused an issue. They were not intrusive. They did not cause pain, and he had no other behavioral issues. But at the age of 14 or 15, they began to be more and more vigorous, causing some muscle pain and some embarrassment, and he was seeking treatment. So his parents knew he had Tourette because they had done their homework, but he didn't have the other complicating features. They were not terribly intrusive, so he did not come to medical care for quite a while. On the other hand, for him it was not an issue. For many it is. Many clinicians are not well prepared to identify Tourette or to treat Tourette. They say Tourette Syndrome, and they put a child on what I would call a heavy-duty medicine like Haldol, even if the tics are not intrusive, and I don't think that's doing a service to the child. Differential diagnosis, that's really a medical terminology for, these are the things that we think it could be. So a child can have a movement mannerism, and very often I have kids come to me, and they come with an EEG because everybody thinks it's seizures. Sometimes they think it's Sydenham's chorea, which is a fair bet, because choreiform movements often mimic tics. They look like it, and they're absolutely involuntary. Sometimes parents think their child has allergies or vision problems or behavior problems, when in fact they're all tics. So here are some common obsessions. Obsessions means thoughts. So many kids will have mental echolalia. They'll just mentally think of something over and over and over. Often it's a word or phrase. They'll sometimes have a need for exactness or symmetry, where they'll have evening up behaviors. I always give the example of, I probably have a little touch of this myself, in eating M&Ms as say a 12-year-old, I'd pour all the colors out and I'd put them all in groups, and then they'd be in the red and the yellow and the green and the blue and the brown and the light brown, and I'd go, I don't like that. They all have to be in groups of 4. So each one would be in a group of 4. Then I got hungry and ate one. Then they'd have to be in groups of 3. So that was how I ate my M&Ms. Sometimes kids will present with very aggressive or violent thoughts, and that's pretty concerning to parents, and they wonder, what kind of a child they have. Some children have obscene thoughts, or they're obsessed with thoughts of sex or exposing themselves. And some kids get into counting or grouping. Some children will say, well, my favorite number is, and they'll tell you, and they get into, like with the M&Ms example, they get into the counting and the grouping. Some compulsions, that's activities where they do things. So they place objects just right. They line things up. I had one child come here who the mother could not take this child to the grocery store because he would literally stop her and spend hours making sure that all the soup cans were exactly lined up, and he'd be very upset if she tried to interrupt him so they could leave the store. Touching or tapping mannerisms, checking or rechecking, smelling and licking things. I have one child who I used to take care of, and I think he still sees Dr. Brown, but I don't see him anymore. The father took him to a Phillies game, and they got out of the car at the parking lot, and the child had a licking compulsion where he proceeded to lick every single car on the way to the entrance to the stadium. And after, 20 minutes of this, and they had only gone 15 feet or so, the father just picked him up, put him back in the car, and drove home. It was so intrusive, and he could not move him from this activity. Some kids get into cleaning or washing things or repeating things over and over and over. Unusual presentations for tics: throat clearing to the point of panic, where a child feels like they can't breathe. Severe neck pain from head tossing. And I've actually seen children do some very damaging things from a real vigorous head snapping mannerism. Eye pain from eye squinting. Serial movements, like movements in sequence. Stuttering can be a tic that is an unusual presentation. Compulsions, cleaning the car for 7 hours, organizing baseball cards, temper tantrums because the bathing suit doesn't feel right or it has a string. Inability to drink from a cup that somebody else has touched, or some children, and I've actually seen this before, have the compulsion to touch the burners on the stove in order, whether or not the burner is on. And again, here's coprolalia, little kids who will say penis breath or asshole mother and then follow it with the F word. Shove it, just shove it, and did I say that? And sometimes giving the middle finger repeatedly is what they call copropraxia, which is not words, it is actions. Just backing up one bit there, just to let you know, coprolalia and copropraxia are actually incredibly uncommon with Tourette syndrome. We have a database here of about 3,800 patients with Tourette, and I think I can count on one hand the number who have coprolalia to the point that anybody notices it. So the neurobiology, we generally believe that this is genetic in origin in some way. As I said before, when they find the gene for Tourette, they're going to find the genes for all of those others clustered very near it. There's been some look into neuroanatomic or neurochemical issues, and we believe that's probably how it expresses itself, but we still don't understand completely how this works. We do know that it's likely a basal ganglia dysfunction because the basal ganglia is responsible for unintentional movements. We believe it's a central neurotransmitter disturbance, and I've just kind of listed here for you probably a dopamine disturbance, therefore neuroleptics have been useful, a serotonin disturbance, so the Prozac-like drugs are pretty helpful. Norepinephrine disturbance, so the alpha-adrenergic agonists are helpful, and GABA, so that the benzodiazepines, like the Valium-like drugs, can be somewhat helpful. Okay, epidemiology, we know that twin studies have showed us that if you are a monozygotic twin, as in an identical twin, and you have Tourette, your twin is very, very likely to have Tourette as well. Chronic tics is even a higher incidence versus the Tourette syndrome, so 75 to 90%. Dizygotic twins, that's fraternal twins, is just like having a sibling with Tourette. So you have a higher likelihood than the general population, but certainly not nearly what it is like if you have an identical twin with the same DNA, the same genetic codes. So here are some behavioral approaches. So that people understand this completely, tics do not get better with talk therapy. Okay, you cannot go through talk therapy and go into this, gee, why am I doing this? And if I figure out why I'm doing it, then I'll stop doing it. It doesn't really work. Tics are an involuntary thing, rather like a sneeze. And if you have to sneeze, you have to sneeze. You can suppress it for a while, but while you're suppressing it, you're not paying a lot of attention to the other things in the world. Think of this. You're in the middle of church or synagogue or class. You have to sneeze. What do? You pinch your nose, you squeeze your eyes shut, and you say, I won't, I won't, I won't. And as soon as you let go of your nose and you open your eyes, and especially if you look at a bright light, you sneeze anyway. But while your eyes are closed and you're pinching your nose and you're trying not to, you're not paying attention to what's going on. Tic substitution can be helpful. So if you have a child who picks his cuticles to the point of bleeding, you can substitute a couche ball, which are those funny little rubbery pom-pom type balls. And kids can pick them until they're just happy as little clams. And somebody, of course, has to clean up the little rubber pieces, but at least it's not bloody. Timeouts to get the tic out of the system. A lot of kids will go to the nurse's office and just kind of shake it out, or go to the restroom to shake it out, and that's somewhat helpful. For obsessive-compulsive ritual-type behaviors, counseling can be helpful. Cognitive behavioral therapy has been extremely useful, and please do check out Tamar Chansky's books. Tamar Chansky is a local psychologist. She is in the Plymouth Meeting, Ardmore area, and she is our local expert on children with OCD and anxiety. So if you check out her name on Google, you'll find her two books called Freeing Your Child from OCD and Freeing Your Child from Anxiety. They're excellent. Oppositional defiance, counseling using logical consequences and developing insight can be helpful. Again, it's really easy to say, find a logical consequence for a child's behavioral issues, but once you work on that, usually with some coaching with a good psychologist, it can be pretty helpful. Temper outbursts, counseling again to develop insight. Aggression, counseling with logical consequences and to develop insight can be helpful. More behavioral approaches for social skills deficits, which are a huge problem with these children. Social skills training or classes can be very valuable, and there are a number of these programs all through New Jersey. You're actually very rich in resources over there for help in this particular area. Social skills training is best done in a group because if you need to learn how to get along with others and how to relate to them, it's best to do it if you have somebody to relate to. So it's done in a school setting or in a club or something like that. It can be really helpful. Groups that have been set up for children with very mild autistic spectrum disorders are often very appropriate for kids with Tourette as well. And in fact, there's one such group called the Lego Therapy, Legos as in the little building blocks. with somebody named Dan Legoff over in the Voorhees area who does this with children with Asperger's disorder, and he's been extremely successful with it, and it's really an intriguing way to deal with social skills. For attention deficit, coaching for organizational skills, use of daily planners. Teachers and parents absolutely must be involved. We know of one child who, with the advent of the Palm Pilot, his parents got him a Palm, and he thought that was such a cool little gadget that he got himself very well organized. So for him, it took a gadget that intrigued him, and he learned some of the skills for organization. Hyperactivity and impulsivity, structure helps a great deal, and the structure can be imposed from the outside because most of the time it's the younger child who's affected by this, and they don't know how to build their own structure. Point system, token economy systems can be very helpful. Learning problems, this is where you need to get the school involved doing learning support, do the IEPs, which is the Individual Educational Plan, and 504 accommodations. Okay, going on to meds. The first-line meds for tics, clonidine and guanfacine have been first-line meds for a long time. Clonidine is the older of these two. They're in the same class, and they can be helpful in probably 50 to 60% of children with tics. Clonazepam, same thing, is a Valium-like medicine, and for the child who has anxiety-driven tics, this can be helpful, but it probably only helps in about 50% of kids. Second-line meds are the neuroleptics, also known as the antipsychotic meds, and if you just look at the bottom of that slide, the side effect profile is a little scary. Although it's very helpful in a lot of kids, you look at that side effect profile and you go, ooh, not my child. I don't really want him on that med. On the other hand, if we need to use it because the tics are so intrusive and we can get nowhere with other meds, we'll use them. Haldol or haloperidol was the first. ORAP was another. It's a very old one. Risperdal or risperidone has been very helpful with some children. And Abilify is the newest. We don't use these very often, but we do use them. Atypical medicines for tics. The nicotine patch is used on an as-needed basis. Some people say they morally have a real hard time putting a kid on the nicotine patch as it is an addictive medication. In fact, it is addictive only when smoked by taking hits of cigarette smoke. When you put it on as a patch, it is not addictive. However, it does have a significant side effect profile, mostly associated with tummy upset and vomiting. So it's not a comfortable medicine. However, it has been known to interrupt the tic cycle for some children, not used certainly in all of them. The SRIs, the Prozac-like medicines, have been helpful in some kids. Trazodone and nifazodone are two medicines that I have not used, but others have. And the ones that I have been more involved in are the topiramate studies. We were actually involved in a drug trial with topiramate, also known as Topamax. And Keppra, I understand, is having a drug trial up in Canada. And frankly, we have had tremendous efficacy with topiramate with children and adults with tics, with very little side effects because we tend to use very tiny doses of these meds. They're both anti-epilepsy medicines. Topamax is also known to be used with migraine, but for tics, it's not approved by the FDA, but we've been using it because we've seen that it's been very helpful. We were involved in a study which was prematurely closed because people were not recruiting across the country, so we didn't have enough to continue the study. Meds for OCD, the serotonin reuptake inhibitors like Prozac, Luvox, which was known as fluvoxamine. Luvox is actually no longer made as a brand name med. It's only available in generic. Then there was Paxil, Zoloft, Celexa, and several others. Other meds for OCD is the serotonin norepinephrine reuptake inhibitors. Anafranil is clomipramine, and Effexor, venlafaxine, have been helpful. Others, Risperdal, which we noticed we often will use for tics, Abilify, which we've used for tics, buspirone is an anti-anxiety agent, which has been helpful for some children. Some people say it's only about as good as water, but you know what? For the child for whom it's effective, it's very effective, but it's not effective for many. Tricyclic antidepressants, and actually the anafranil is one of these. It kind of crosses two different drug types. They can be helpful, but we use them with caution, since the SRIs tend to be safer and more effective. Medications for ADHD, the old standby, the gold standard, is methylphenidate, also known as Ritalin, which now comes in so many forms I can't even list them all here, so this is a short group of them. They're long-acting Ritalin like Concerta or Ritalin LA. Focalin is a different preparation, but still Ritalin. Daytrana patch is just a patch that you put on the skin and you leave it on as long as you need it and take it off before bedtime. Kind of an intriguing idea, and it's been pretty helpful. Adderall, or the mixed salts of amphetamines, clonidine and guanfacine, which you'll remember from the first-line meds for tics, antidepressants, and the newest one is Strattera, also known as atomoxetine, which is a norepinephrine reuptake inhibitor. So the prognosis for kids with Tourette syndrome, overall it's really pretty good. The tic symptoms tend to be worse between the ages of 10 to 15, and then they tend to fade. Now, again, if you look at a bell-shaped curve, there are always going to be some outliers. I've had some kids in the practice who begin ticking and get very, very vigorous tics before the age of 3 or 5 even. And I've had some kids who tend to get worse and worse, and they're 18, 19, 20, and their tics are still very vigorous and very intrusive. But the most frequent picture I see is kids who start with tics, they get worse, and then they start to get better by the time they're 13 to 15 years of age. Often when they get in the late teenage or adult years, they're left with the fallout of the other stuff, the emotional and behavioral issues that have been kind of left over and perhaps not addressed as well as it should have been. The course of this disorder in adulthood is quite variable. The interesting thing is the repertoire of tics as an adult tend to be pretty stable. They don't vary as much as they do in childhood. Major challenges for children is educational achievement, and as adults is stable employment. There's a poor prognosis associated with adverse perinatal events. What that means is if you have a baby who had a stroke in utero or had brain damage at the time of birth and has Tourette syndrome, they tend to not do as well. Developmental or mental disorders that are going along with the Tourette disorder tend to make the prognosis a little bit more difficult, and they're more difficult to treat. Chronic physical illness makes it more difficult to treat. Unstable, unsupportive family or school environments makes it more difficult to treat. And exposure to psychoactive or street drugs and alcohol. Potential complications are treatment-resistant OCD. This doesn't happen frequently, but when it happens, it's tough. Major mental illness, such as major depression, bipolar disorder, or schizophrenia, make it very difficult to treat the Tourette syndrome. What they call character pathology or personality disorders make it more difficult. And children who actually actively abuse street substances. For the most part, children and adolescents really do quite well, especially if, one, the symptoms are recognized early enough so that the self-esteem is not damaged. Number two, so the caregivers have adequate understanding of the symptoms, because too many times the parents will say to me, I know he can control it. I tell him to stop it, and he stops it, and then he starts it up again, just like he's saying, the heck with you, I'm going to do it anyway. And that really is poor understanding of the disorder. And number three, when the caregivers have realistic expectations of what the treatment options are and what we hope to achieve. So we're going back to this slide before, and we'll leave this on for a second so you can just quickly review the different programs and services that the Tourette Syndrome or the New Jersey Center for Tourette Syndrome and Associated Disorders supports. There are many, many programs that it supports, and it's a wonderful organization. And back to this one, we'll leave this on at least for the time being so you can write down this information. Please also understand that at the end of this presentation, we are going to, hopefully, in a few days, we'll have this presentation up and running on the website for the New Jersey Center for Tourette Syndrome, so that if you missed any part of this, you can go back to it and gather some information. So now I think it's time for questions and answers, and I'm going to turn this back over to you, Kelly, because I know you've probably been fielding some, and perhaps we can help folks out who have some questions for me.
Okay. Do the psychological symptoms also tend to fade after 15 years? Was posted by Carla.
Okay, so the question is, do the psychological symptoms tend to fade after the age of 15 years? And that's, did I get that right?
It didn't say age, it just said fade after 15 years.
Fade after 15 years. Okay. So that's kind of a difficult question. I think, I don't know that depends so much on the natural course of Tourette syndrome. Probably it depends a lot more on what has gone before, how has the child been treated by the healthcare professionals, how knowledgeable are the parents on, dealing with the psychological symptoms, and how effective is the treatment for the psychological symptoms. Some of the toughest symptoms are the oppositional defiant disorder, and that is, I always say, when your child has ODD, this is a long-term issue that needs long-term care and coaching, because just when you think that your child is getting better from that, then they kind of drop the other shoe on you, and you go, oh my gosh, now what do we do again? So you have to be ever vigilant with that. But I can probably answer this question maybe a little bit better on the website, because I'll try to speak to it more completely.
Okay, we have another question on posted by Elaine, asking if you have any suggestions for dealing with coprolalia.
Okay, so the question is, do I have any suggestions for dealing with coprolalia? Substitution can sometimes work. So if the word is the nasty F word, I'd sure rather hear the not-so-nasty F word, which is, F-A-R-T. And sometimes if you can kind of soften the coprolalia so it's a less offensive word, that would be useful. I actually have somebody here in neurology that I work with, no names, not even any positions, but this person tends to adjust the glasses by using the middle finger, which looks for all the world like he's flipping the bird. So the suggestion would be, instead of that, use your little finger instead of the middle finger. So substitution may be helpful, but medications can also be helpful for that.
Okay, Monica asks, what symptoms of attention deficit disorder with kids? What are the symptoms of attention deficit disorder with kids that have chronic tic disorder?
The symptoms of attention deficit hyperactivity disorder are going to be very similar, pretty much the same in a child with tic disorder as they would be in a child without tic disorder. The differences you may see is if the tics are very vigorous, it may obscure the attention deficit disorder to the point where you're not aware of it until you take care of the tics. And sometimes, and this is kind of an important point, if you have a child with tic disorder who is working very hard to suppress their tics during school, they are probably not paying attention the way they should for learning what they need to learn. So it's a muddy question in that way, that sometimes what you think is ADHD may not be. It may be suppression of tics.
Okay. There was a book you referenced on OCD. Can you repeat the name of the author, please?
Okay. Her name is Tamar. That's T as in Thomas, A, M as in Mary, A-R. That's her first name. Chansky, C-H-A-N as in Nancy, S as in Sam, K-Y. If you Google her name, you'll come up to her books. I've
read opposing views on tic triggers. are things like food additives, caffeine, food dyes triggers, and what about environmental triggers?
Good question. I think there is no blanket answer to that because I think every child is different. I think if you have discovered a trigger in your child, don't assume that it's for everybody, or if somebody else has discovered it and written a book, don't assume that it's a trigger for your child. I know that with my own child who does not have Tourette, but he had some of the behavioral issues, for a while there, probably for 3 or 4 years, you give that child a yellow lollipop, and he absolutely went ballistic. And we blinded this. The babysitter actually gave him the yellow lollipop and didn't tell me about it. And I didn't know what happened to him. He was just a wild man. So I think the best answer I can give you is it's so individual that I wouldn't make any blanket rules about that. Too much sugar for any child is not a good thing. It gives them way too much energy to do whatever it is that they, behaviors they do. Too much caffeine is not good for any of us, and it makes you wiggly, inattentive, and have this internal restlessness that's pretty uncomfortable. So I hope that answers that question.
Can some of the drugs used for the treatment of OCD make the tics worse?
Good question. That has not really been my experience. And in fact, if anything, they either have no effect on the tics or they make the tics somewhat better. And I think the reason for that is tics can be anxiety-driven. Those of you who have children with Tourette, you'll notice that times when there's high anxiety or high stress, their tics are going to be worse. And if we lower that stress, their tics tend to get better. And those meds for OCD tend to lower the level of anxiety. So many of the kids actually get better.
Behavioral interventions for aggression or impulsivity. What appropriate logical consequences if the child also has ODD behaviors?
Oh, that's a tough one. It really depends on what the behavior is. If a child picks up something, some little, like a piece of tissue, and throws it at the mother, I don't know that I would have a logical consequence because no damage is done. Yes, they threw something, but it wasn't an object that would hurt. So on that one, I would probably turn my back and absolutely ignore. So what you're doing, in effect, is not reinforcing the bad behavior by giving any attention whatsoever. If, however, you have a child who throws a glass of milk and makes a mess on the floor, yeah, I know it's a whole lot easier if you clean it up. But
so what if this child is in young adulthood, around 16?
And does that?
Well, sorry, no.
Well, I was going to say, if that child is small and does that, you go through the motions of making the child clean it up. Now, that doesn't mean you tell him so much. I mean, if you tell him and he won't, then you lean behind him, you grab his hands, put a sponge in his hand, and just do some motions of cleaning it up. So it becomes you did it, you're responsible for it. Yelling and screaming doesn't work. Sometimes timeout can work. But logical consequences mean you have to really think about what is the logical consequence for this behavior.
Okay. If my child has had simple vocal and motor tics and they are replaced by complex motor or vocal tics, does that mean his Tourette is worsening?
Not necessarily. I think the big question is, are the tics interfering? If the tics are interfering with the ability to read, to feed yourself, if they're causing pain, or if they're causing so much embarrassment that the child does not want to be with his friends, that's what I would call a worsening of tics. Now, I have to tell you, I have a friend who works here. He's a neurologist, okay? He has this very complex but very subtle tic, but it is very complex because it involves 2 vocal tics and a complex motor movement where he lifts his hand to his mouth, he sniffs it, he puts it down, he lifts it up, he sniffs it again, he clears his throat, he lifts it up, he sniffs it again, then he acts like he's wiping his nose and he sniffs it again. That's pretty complex. but it's so subtle that nobody really notices it, not even the people who've worked with him for 20 years. I noticed it just because this is what I do. But it's not a bad tic. He doesn't need medicine.
Okay. You mentioned panic and anxiety in children with TS. What type of therapies can be effective for older children, and who do parents turn to teach and administer these therapies?
Your best bet is to find a psychologist with interest and experience with children with Tourette and related disorders, especially a psychologist who will do cognitive behavioral therapy. Children who have anxiety even very young children do very well with cognitive behavioral therapy.
Okay. We're pretty much at the end of our time. All the other questions, if we haven't gotten to yours, I apologize. But we have come to the end of our time. And all of our questions will be posted on the chat board, and we will be answering them. And again, we'll be answering these throughout the next 7 days in reference to this webinar. This webinar will also be available on the njcts.org website to peruse at your leisure to download. And it'll give us a couple of days to get it up there, but it will be out there for you. Susan, thank you so very much.
Oh, you're most welcome. Thank you, everybody, for attending.
Thank you all for attending our first Wednesday webinar. Look for an email notification of upcoming webinars. We expect to be doing one monthly. And again, check our website at njcts.org on a regular basis. Look at the calendar to see what's posted and what's scheduled. We look forward to talking to you again in the future. Thank you. And Susan, thanks again. Good night, everybody.
Good night.
Thank you.
Ellie, you still there?